I will be finishing up the topic of disorders, and we're going to cover probably 3 of the most severe ones, at least as far as impact on life. Most psychological disorders have an impact on people's lives, but we're going to talk about 3 that are fairly severe. Schizophrenia, mood disorders, of which we'll talk about both depression and manic depression. And then any other questions that you might have. We'll also today look a little bit at this topic, and that is, are psychological disorders in any way, shape, or form related to the spiritual world? Are there ways in which we can begin to look at psychological disorders, and do they have any sort of overlap with what traditionally has been called or seen in different times and contexts, for example, as, let's say, the influence of a demon on a person's life? And we'll look at ways in which we can distinguish this, and we'll do that today as well. Before we start, though, if you do not have an exam score listed on Blackboard for exams 2 or 3, you need to send me an email, because they're all posted. And that way, if you don't have one, you need to let me know, and that way I'll be able to get it scored or find out why your test isn't posted, okay? So that will be, anybody in that position where exam 2 or 3 isn't yet scored? All right, send me a note, so we'll get it posted. Are there any questions before we get started? Anything else? There are experiments posted. You should have those looked at and examined. Yes?
Something that came up recently. A lot of the modern day disorders used to be called chronic mental illnesses, but now they've been given a new name, and saying chronic mental illness has a dark connotation. What is this?
Yeah, we'll talk a little bit about, the question is, are there different names for psychological disorders as the years have gone on? And indeed, there's a honing that takes place quite regularly on disorders. And we are now actually saying it's more specific. And I'll give you some examples of how that works. And in fact, today I'll start with kind of an example of how we've changed our perspective by simply almost labeling something slightly different, and how even that label changes what we look at. And if you remind me, what we'll do is I'll share a little bit of history on that. Another question real quick. Did you have a question over there anywhere? Yeah?
I know you said that the surveys take a while for it to be posted on Blackboard, but what if it's like a survey that was from a long time?
Yeah, even, she asked this, she says she hasn't gotten record yet of surveys that she completed an experiment, and some of those are still to this day being posted. It's not because it takes us long to do it, it's that the person who did the survey is still getting the names to us for us to even do it. So it shouldn't be a problem. By next week, after Thanksgiving, the majority of them will be up and posted, because we're setting deadlines for them. And well, I'm not sure if I can sing very well at happy birthday, but I will tell her. What's your friend's name? Melissa. Happy birthday. Where are you at, Melissa? And how old are you today? 18. Way to go. Well, let's tell Melissa happy birthday. I wish there was an easy way to do this besides singing, but happy birthday. How's that? Okay, go ahead. We'll keep singing. Wonderful. All right, Melissa, happy birthday. I'll say this. Anybody else? I'm sure there's about 2 other people who have a birthday today. Besides Melissa, whose birthday is it? Anybody else? Yes, and tell me your name. And Rita. Did I say it right? Rita? No, not Maria.
Karita.
Huh?
Karita.
You 2 people say it. You say it.
Karita.
Kermita. Thank you. Spell it for me. Oh, Corrida. Me and my hearing, Corrida. It's hard. I'm serious. You have 20 things coming at you. Happy birthday, Corrida. Anybody else? So now we have 1, 2. It's almost always the case.
Do bipolar and schizophrenia also go together?
Yeah, we're going to talk about the connection between what I do. We're going to talk about the connection between whether or not these go together and, what was the last part? Yeah. Do they go together? Bipolar and schizophrenia, and if they go together, how do they work? And I'll talk a little bit if they share some things in common. They're both psychotic or can be disorders. So let me pray for our beginning today as we get started, and we'll get going from here. Lord, we just ask that you're here and present with us. We know that you care deeply for not only the things of this world, but the things that matter to us. You care for us each individually, and you know us thoroughly. You know our hearts. You know us completely and fully. And in many ways, your love for us extends as far as the heights and depths of anything we can measure. And in that regard, we just pause to say thank you for being a God who cares, a God who loves and knows us and has created us. For those that are hurting today, even those that we're going to talk about today related to those suffering from disorders and exploring that, we know that you are a God who understands and knows and walks with us through these things. So thank you for that and for that assurance. Be with us today as we explore these things now, and your presence here, we thank you in Jesus' name. Amen. We have spent a lot of time looking at, and today I'm going to look at some psychological disorders that we ended with last time, and one of those is schizophrenia. But before I get off on the topic of schizophrenia and then finalize it and then tie it into other types of similar disorders, including mood disorders, let me tell you that this is a tough area because we talked about in here the number of people that suffer from these disorders, but there are a variety of disorders that aren't as common that we're not even talking about. There's for example, the way a lot of some of the therapeutic techniques started to helping people with certain disorders all had to do with ways in which you viewed a particular disorder. So I'll talk historically about one that we no longer even use this as classifying, but it was very common 150 years ago. We would say that people who had a particular kind of psychological disorder that resulted in physical changes had something called, they were dealing with hysteria. Have you ever heard of hysteria? People who were hysterical, or well, we don't use that very frequently, and now it's not even used the way it used to be. But anybody know where that word came from? Who suffered from hysterics back 120 years ago or so? Who was the likely population that would be diagnosed as having a hysteric disorder? Would it be males or females? It was almost always females. Well, what's interesting about that type of disorder was it resulted in some physical manifestations or changes, things that would happen up here. We knew there were stressful life events that a person had, and it would result in somebody, let's say, and oftentimes a female, in a weird, maybe part of their body would go numb. Like I'd mentioned before, the glove hand syndrome, a glove paralysis, or there'd be a weird tic or a strange way in which the body would respond to what was seemed to be some things going on up in the mind, but no one realized that a thought like that could result in a body being so impacted. Well, then something strange happened. You see, only females at the turn of the last century were those that were diagnosed with hysteria. It was a female disorder. And then something happened in the early 19th century that changed that. Anybody know what happened? There were men who were coming back out of World War I with physical symptoms that looked just like hysteria. They would come back with tics. They would come out of the war zone with kind of an inability to use a leg or an arm. And frequently, many of these soldiers had just experienced somebody next to them dying or there were trauma on the fields of battle that resulted in them having physical melodies that couldn't be explained. And that was primarily, now this is all of a sudden, wait a minute, this is not something men suffer with. In fact, they came up with a brand new name for this. They didn't call it hysteria. What did they call it?
Post-traumatic stress.
They called it then shell shock. You see, it was this shock of being exposed to these shells that would cause these men to create these physical odd symptoms, and they'd come back with these strangest physical problems. But the bad part was, the doctor by the name of Charcot in France did something to these soldiers that was both good and bad. What was the good? What did Charcot in France do that helped these soldiers who came back with shell shock because they couldn't walk very well, or they'd be paralyzed on parts of their bodies and have these odd things? The good was he figured out how to help them. How did he help them? And Freud, by the way, was there watching as one of the many people who came alongside and watching his technique to getting these people with shell shock back on their feet again, so to speak, just by simply, what? Talking to them. Asking them, what happened? What experience was that you had? Tell me about the moment. And they would go through these horrible, traumatic memories of my buddy right next to me, and we're fighting, and then a shell, and then boom, and then he's gone. And there's just parts of him. And all of a sudden now the body responds in a way that was strange. Well, as he began to explore and talk to these soldiers, guess what happened? It began to loosen its grip on them, and they began to recover. That was the good. The bad was, as soon as they recovered, they put them right back into the war. But it began this process. Is the mind sufficient enough and a thought sufficient enough to cause changes physically in you? Is there some trauma that can happen to you? We used to call these psychosomatic. Have you ever heard of that? Where something psychological happens and it creates some physical things. We more commonly refer to these as somatoform disorders. Is the brain powerful enough to cause you to think differently? But importantly, we know that is, but is the mind more important, besides changing thoughts, to change your physical body, to cause paralysis, to cause weird things to happen? Two boys are standing around in a swimming pool. They're about 4 years of age. One of them, they're twins. One of them is dealing with some visual problems, but he's still able to have use of his eyes and to see, except for one very sad thing happened. This was about early in this century in a poor part of our country. Two little boys in a swimming pool, actually just like a little waiting area, but the mom was watching them, and she kind of turned away for just a few minutes. In that time, one of the boys fell, hit his head, and began to drown. The other, his brother, stood there watching this, was so traumatized, didn't know what to do, how to help, watching his brother struggle. And his brother, in that brief amount of time, took in enough water that he died. By the time the mom saw him, a neighbor came over. The boy that survived his brother's drowning death was traumatized. And from that point forward, he began really almost experiencing something that the soldiers experienced. And this little boy began losing his eyesight and lost it completely. It was almost as if his body responded to the stress by doing what? By shutting out the world. And he he never saw from that period of his time forward. He is now, he's functionally blind. This little boy named Raymond, and you know him because his name was Ray Charles. How many have heard of Ray Charles, the singer? That's Ray Charles' story. Now, is it possible that Ray Charles could have gotten help, much like Charcot offered victims that were dealing with these things? And if somebody could have talked to him, he's from a poor part of the country. They didn't have these experiences. We weren't even sure what was going on back then. Didn't even know if this was related. But is it possible to have taken somebody like that and to fix them and to help them? By the way, a somatoform disorder like this is not very common. In fact, it's rare. We're going to talk about other things, but these are just some examples of the ways in which we're finding that the way we think, behaviors and experiences that happen to us and our emotions that are up here can actually affect very important physical things in our bodies. Yeah, do you have a question? It's a great question. Could it have been reversed? The answer is if you had probably caught this soon enough. And there was some debate as to whether or not there were enough visual problems that this might have happened eventually anyway. But my guess is if it had been caught early enough, the answer, it could have been reversed. Given a couple of years of that process, it was probably irreversible. Atrophy and other things occurred. And there wasn't, after a while, it wouldn't have mattered. But yeah, that's at least the idea out there. We'll probably never know that. Psychological disorders have huge impacts. Sometimes they're just changing thoughts, like in schizophrenia, this disorganized thinking, but it has huge consequences. Ultimately, what I want to show you today then are just a few more examples. I'm going to show you some people that are dealing with certain disorders. We looked at this idea and this list of symptoms. Do you have any questions about these symptoms that were talked about last time? I want to show you right now a quick video clip of a person who shows all of these symptoms. He's currently, or at least by the time of this old film, was hospitalized, showing bizarre delusions, thinking, disturbed emotions, social withdrawal, and then paranoid thinking. So let me show you real quick what this looks like for him and his life, and then I'll show you some others. So let's hit play. Let's see, talk again.
Gerald has grossly delusional and thought disorder. He is currently on the following medications: haloperidol, 32 milligrams daily; benztropine B, 4 milligrams daily.
How you doing? I do say I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in. Is this a new feeling for you? The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
Must be very frightening for you then. Feels like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache? Could
You want to know?
Yes, I do.
Okay, when a sperm and egg go together to make a baby, only one sperm goes up in that egg. And when they touch, there's 2 contact points that touch before the other 2. And then it's carried up into the air. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the protons. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to 1 atom.
Just so you know, he's showing, early on you heard some of the paranoid thinking about people out to get him, blah, blah, blah. He's so scared, this, that, and then what you're listening to now is right up here, this idea of a loose word association, something we call a word salad. That is, he'll just kind of take things and bring them together, and you're following along for a minute, and it seems to make sense, and then it just veers off. And then you just have a hard time kind of following exactly what he's saying. So watch for these kinds of things in the middle screen. You'll see it occur again in other ways.
In one patient at one time shows almost every one of the major features of schizophrenia. His thinking is disorganized. The thoughts are loosely connected. He has formed delusional ideas. Some of those delusions are grandiose. Some of them are paranoid. He has disturbances in his mood. His mood is, in some cases, almost absent, and in other cases is totally inappropriate. And And his behavior is disordered. It's unusual. He has mannerisms that are inexplicable. He has purposeless, aimless behavior around the ward. He's a textbook case. He combines all those things in one person.
At this point, what would you like us to do for you?
I would like you to get me off of cigarettes, get me dried out, cleaned up so I can go home and get a job in the bakery and go to medical school.
I guess the way I think of schizophrenia is that schizophrenia is an illness. It's a total picture. It's not like a peculiarity of behavior. It's not as if somebody has a sort of idiosyncrasy or has some peculiar way of doing things or thinking things. Schizophrenia is an involvement of a person's illness. There is abnormalities of behavior. There are abnormalities of thinking. There are abnormalities of feeling. There are abnormalities in the way people move across a room. There are peculiarities in what people perceive. There seems to be a very global impairment of what we think of as the highest psychological functions, the most intricate, sophisticated, complex psychological functions that people have.
What happens is you've got a healthy, or can have a relatively healthy young adult, or a young person turning into adulthood, who begins to go into a psychosis, withdraws from the people who he or she loves, and is distant from those people. At the same time, that individual, that child, is clearly in enormous emotional pain, psychological pain, can't interact with people, and has a disease which can last for years.
This is a pretty standard looking ward. They're not locked up. Many of these schizophrenics, they can walk around freely. They're paranoid though. You'll watch them go into their rooms and shut their doors. They're afraid of certain kinds of things. But this is pretty standard. You could walk around, talk with them, visit with them, even though they're hospitalized.
In order to understand the kinds of patients that we have on this ward, you've got to remember that schizophrenia breaks down into the rule of thirds, we say. A third of the people who get the disease will get well and not get sick again. A third will get sick off and on and spend some time in the hospital, but a lot of time out of the hospital. The third, the real chronic schizophrenics, are the people that make up this ward. Are you going to be going home this weekend? Chronic schizophrenics, when they've had the disease for more than a few years, almost certainly have some brain damage from the disease.
This would be a good example right here. He might not ever move. If you're there 6-7 hours, he might not move. Catatonic schizophrenia is a subtype. I worked with a schizophrenic who this is all he did the entire day at the hospital. He had, I think it was the Quran, I'm not sure, to his chest, and there would be this kind of movement, this kind of a back and forth that was just within about maybe 8 to 10 steps, and it was a repetitive, constant, just back and forth. Some catatonics won't even move. He'll just be stuck here like this. It's a subtype, but involves this kind of almost taking over, which is why it's, again, called a catatonic state. So that's what this is.
Chemical, physical processes that cause the disease cause some damage to the brain. It's sad because you have people who looked normal for the first 15, 17, 20 years of their life. And then you have this devastating illness, so that there is this disconnect between the way they are early in life and then the way many of them have to spend the rest of their lives.
Let me show you also now what happens when they get out. This is another one is David out on the street, who will feel more comfortable there. Sorry, we'll start this again.
Schizophrenia strikes 1 in 100. There are different degrees of severity. But to see the disease at its most severe is to see it untreated. We first met David when he had just come in from the cold to Project Reach Out. Although he agreed to talk to our producer, DeWitt Sage, he was also deeply suspicious. David is a paranoid schizophrenic.
My stomach kind of gives me trouble when I don't have enough sleep. The stomach and the legs are the two things that tend to most prominently go when I
tonight's Mike Mastrogiovanni is David's caseworker.
Happens often.
What happened to the lens there?
They fell off my face one day, their glass, and they were cold, and probably it was cold, so they were probably a little extra brittle and mango.
Because this happened since the last time I saw you, right? Which was
a couple days ago, yeah. It fell and hit the sidewalk, and it's glass lens, so.
Have you confirmed your prescription? Is it the right prescription? You were going to check that out?
I haven't, I can't answer that at the moment, but the reason that I'm setting it up so that I can confirm the prescription is having had lenses stolen, so on tape, having had glasses disappeared and reappear when I squat. So I definitely must, so that I can be safe crossing streets, make sure that I get the correct prescription. And that means all the way from the stage of getting the prescription to actually having the glasses made. And one other thing I really appreciate in light of what else is on the tape, this is going to make sense. I really appreciate if there's no transmitter embedded in the frame. Okay.
I would hope that that's not the case.
Like the one that's probably here. Anyway, folks. This one gets lost on the cutting room floor for sure. I am probably or possibly under surveillance by a Drug Enforcement Administration, private investigative officials, and various units of the NYPD. The FBI once told me that they weren't interested in me, which was kind of refreshing to know.
David, let me ask. The FBI, all of this intense surveillance, could this be part of an illness that you have?
Nice try. When you say, well, maybe it's just something I'm thinking of and product of my situation. When it happens 120, 150 times, I mean, let's take an example. Someone might be reading a book and leave it on a telephone booth as he's making a call. Someone might do that, and sometimes that book might be a really attractive book or an expensive book, or somebody else might have liked that book, and that book might not be there when you turn back, say, 30 seconds later. Okay? When that happens 30 or 40 times, and sometimes those books are obviously of no conceivable cash value to anybody, and sometimes the books contain your identification documents and your money, which nobody but someone maintaining close surveillance on you could have discovered. See, when determining whether something is real or something is not real, it's real simple. Get the facts.
It's a tough world. That notion for him of having dealing with things and being worried about it, it's just simply a hallmark for him when it comes to this paranoid thinking. And I told just this weekend, I sat there with a schizophrenic who clearly was he'd been in this neighborhood. Many of you have probably seen him around, and we just simply sat there, and I had a meal with him, and he did this. You would ask him questions about what he's doing, and then I'd say, "Are you getting the right sleep? You got a place to sleep? Are you staying dry?" "Oh yeah, I'm fine. I'm staying dry." "Tell him about medication. Are you taking?" "No." And he, "Nope, don't need it." And then he started talking about how his brain has been adjusted in a variety of different ways in 4 different places. And in that adjustment there, and he starts into this process, and you start to realize that this disorder has caused him huge consequences that are part of this lack of thinking clearly, but it's also because he's paranoid. He thinks that people are kind of trying to push things on him, and so he'll resist it and say no, and then he'll go into stories that kind of help him say, I'm doing fine if people would just leave me alone, and you're trying to hurt me more. And so you can see where the difficulty comes in with somebody like this. It's trying to help is perceived oftentimes as you're just trying to hurt me again. And all of this is now coming out to play where you have more and more on the streets individuals who are clearly in need but are finding that they can't trust other people. But this woman here would have an experience similar. I don't know if this is going to play or not, but I'll show you what she would be experiencing as well in this.
I get to the point where I don't want to live anymore because the mental process of mine takes over. When I think I'm doing good for a while, something mental takes over and it scares me. Years ago, I didn't do that. Years ago, I didn't have to worry about that one thing. I was one less paranoid. I mean, one less crazy. I was one less crazy. I mean, years ago, I didn't have this new mental problem. I don't know what it is. I don't know what it is, but it's pretty scary. That's why I called the police. Nobody else was doing it. But those people at 7-Eleven, they're always on the phone talking about me. Always. Especially in the summertime, nice weather. They're always talking about me, calling hospitals, Barnes, St. John's. There's a lot of doctors at not 7-Eleven, Quick Trip. You know what Quick Trip is? There's always a lot of doctors and nurses going there making porn, like kill her or do something to her.
Do you notice changes in your attention, with your illness?
Huh?
Do you notice changes in attention with your illness?
I'm retarded.
Do you notice having problems focusing attention or keeping your attention on things?
Yeah.
Tell me about that.
I don't know. What was that again?
When's the last time you felt good?
I don't remember. It's killing me. It's killing me from having a boyfriend, giving me some drugs. It's killing me. Like in China or somewhere. I just believe if somebody's been suffering years ago, you should take an OD and die, because psychologically you may not want to take the OD, but to get out of the misery, you might. They fight it every night, and every day he's always fighting with me. Michael's always fighting with me. Drug dead, thief, retarded dead. Oh, that doesn't mean shit to me anymore. I'm so used to it. I do have a brain. But I don't have a brain.
All right, what you're seeing is one of the reasons some people, by the way, go into the field, and that is they try and say, we've got to figure out a way to help. What can we do? How does this start? Where does it come from? The onset is an important piece to this. Your book clarifies this a little bit more, but there are what we call certain kinds of early onset or sudden onset that we call reactive schizophrenia, which means that the prognosis is good because it tends to come upon suddenly. That is, over a couple of months, you might have a person who is fairly, quote, normal, and then just in a matter of a short period of time, 2, 3, 4 months, begins to show signs of this. Oftentimes this kind of reactive schizophrenia usually tends to have a better prognosis than what we call progress or process schizophrenia. Process schizophrenia means there's a gradual onset. An individual that is at 14 starting to show some symptoms or signs, at 15 or 16 a few more, at 17 or 18 even more signs, and then they plunge into a very much more deeper area over the course of time. In a gradual onset does not have as good a prognosis of getting better as someone with reactive. Yeah, go ahead.
At 14 or 15, what kind of signs would there be?
Well, there's symptoms that usually start to show, it may not be as early as 14, but around, let's say, 16, 17, just starting to, their thoughts start to get a little bit confused, let's say. They begin to believe certain things that they are struggling with, let's say, like paranoid thinking, that somebody is following them or out to get them or keep. Now, these thoughts, for many people, you can have that thought out for some time, but it's this person who is unable to stop thinking that, and then it begins to increase in how frequently it occurs or how strongly they start to feel this. Then they begin to show, a few more signs, like a certain kind of social withdrawal that's, maybe some of these, emotional issues where, so it's just a simple gradual thing that you'll start to pick up. And there's no, set true course. These things can vary, by person. But these are really ways in which you start to find this becomes what we call a category of disorders, a group of disorders, rather than a specific disorder. And so some of the specific clusters of symptoms would be things that we've talked about in here, like for, let's say, catatonic, I mentioned, there might be a physical manifestation that's stronger. For paranoids, you would have this kind of clustering of symptoms, and so they would be diagnosed with paranoid schizophrenia. But oftentimes, you'll see this in your textbook, different kinds or categories of schizophrenia that are there. So look at it. Yeah, go ahead. Like a physical, you mean? Is it genetic? Yeah. Well, the answer is schizophrenia does have a genetic component to it. In fact, what I'll show you is it's one of the main causes. And so the answer is yes. It's not the full answer. And the reason we know it's not the full answer is because of twin studies. If you take an identical twin, one of them who is diagnosed with schizophrenia, if this was a fully genetic disorder that was passed down genetically, if you have an identical twin who shows signs and develops schizophrenia, if it was fully genetic, what would be the odds of their identical twin having schizophrenia? It'd be 100%. And yet in twin studies, it's around 50% likelihood. Does that make sense? If you have an identical twin who is diagnosed with schizophrenia, your odds have now increased up to about, you have a 1 in 2 chance of developing schizophrenia yourself. And so you can see here, genetically, even though they're 100% related, an identical twin only has a 50-50 chance if their twin has been diagnosed with schizophrenia. If both of your parents are schizophrenic, you have a 50-50 chance, which also tells you genetics play a big role, but it's not the complete picture. Your odds, by the way, just as out in the population, is 1 in 100. That's the odds of developing schizophrenia, 1 in 100. But if you have a fraternal twin, it goes up to about 14%. That's about 13% if you have one of your parents. If you have a brother or sister, your odds increase from 1 out of 100 to 10 out of 100, 10%. And then if you marry somebody that's schizophrenic, you double your risk. I'm not sure why, but.
Going back to the onset of schizophrenia, I've heard that people, like if you catch schizophrenia before the age of 17, usually that it's treatable.
Early onset schizophrenia we can talk about. It's a kind of special category. Again, it has a little bit different treatment outcomes than some than others, but I'm not sure about the numbers and how much more, but there is a slight difference. And yeah.
The patients are often continually citing government agents as
Yeah.
following them.
Yeah.
What happens if they've never heard of said agencies?
Yeah. My guess is what they'll do is for individuals that have these views that are especially their feeling, let's say, a type of paranoia, that they will come up with other things. And so I told you about the person who believed dogs they thought they were anthropologists from other planets. And I told you about that, who were sent here to spy on them. So they'll make up other things and come that way, yeah.
I have two questions. The first one is, can other symptoms of schizophrenia be like DID?
Sometimes there's similarities with schizophrenia and other disorders because of the psychosis involved, the lack of clarity of thinking or strange thoughts or the belief that they're even different. So yes, it has some overlap with some disorders like that.
And my other question is, how beyond the schizophrenia can you see it?
You start to find schizophrenia. There can be early diagnoses. It's not common, but I mean, I've known of 4 or 5-year-old children that have been diagnosed. It's not common, but it does happen. There's a girl that was just tracked by one of our local newspapers over the course of time having schizophrenia. She was 7 years old, and how devastating of a disorder it was. Very early, though, from standard. Yeah. By the way, dopamine, as I mentioned before in here, one of the major neurotransmitters that's implicated in this. Your book talks a lot about it as well.
Do the symptoms for schizophrenia change in different cultures?
Symptoms, from culture to culture, you tend to find very similar kinds of things, which is why we can call it a fairly universal disorder that it's not a respecter of boundaries or cultures. And it's because most of the time you find about the same types of symptoms throughout. I'm sure there are some distinctions, I just don't know. Yeah, but go ahead.
And also, can schizophrenia be paired with another disorder like
Yeah.
bipolar?
You can pair, and there are, unfortunately, those that can suffer from not only schizophrenia, but other things. Now, by the way, let's ask this question and start with, what role does the spiritual play in any of these disorders? One, it seems to be fairly interesting in this regard. What role do you think, did you see anything in here? Do you think the role of the spiritual comes into play? In which way or how might it come in? Yeah. She mentioned she has a personal connection to this in her family, and the role of stress comes into play, the role of choices that a person makes with drug use and other things. All of these can exacerbate, create the situation and make it worse. So there might be mediating variables that can come in and make it better or make it worse, and so it could play that role. By the way, there are similarities with certain of these disorders and what have traditionally been thought of as ways that within the idea of a biblical worldview, the belief that there is a spiritual world that operates in a very important way, and that there is such things as existence of a spiritual being, for example, there are similarities, right? I mean, you notice some strange behaviors, strength that could be strong, that can be there, that a person might manifest unique strength or weird, strange, let's say, changes or voices or changes in personality. And these would be some things that we've documented over years in early existence that would give us, say, some pause to say, are there ways in which these look alike? And then of course, just because someone shows strong strength doesn't necessarily mean it's, let's say, a spiritual influence. I was in a home with behaviorally disturbed boys. I told you I don't know if I told you or not, but I worked with 50 boys in this home, and there was one kid who, I'm telling you, had a moment that I'll never forget. He wasn't quite yet 5 foot, and there was me and another counselor in there. This guy was probably 6'4", 6'5". He was almost 300 pounds, and we were talking with this kid, and he became more and more agitated and greater. And I don't know did I tell you this story? He became more and more upset with us, and I could tell he was about to explode. And he even did something today I'm shocked at. There was in front of us, between us, me and the counselor here, the big guy, and the little guy, was a coffee table that I bet, without exaggeration, it had to weigh over 150 pounds. It was this big piece of wood, coffee table. And you could just see him getting angrier and angrier, and he snapped. He reached over, picked up the coffee table, and threw it at us. And I'll just tell you briefly, my only thought was, get behind the big guy. That was my first thought, like, ugh. So I went like that, got behind him, and sure enough, he took the full blow of the coffee table. Yeah, I thought that was a smart move on my part. But what was shocking was that this kid picked that thing up. And I remember thinking, there is no way I knew he was reaching for it, and I thought he was picking up maybe something off of the table. He picked the whole table up. And we ended up, tackling the guy. So another counselor ran in. We had to hold him down. He was little. Now, that's abnormal strength, but it probably is explainable. There are ways. Now, when you start talking about differences, there are very important differences you have to understand. Most of the time, when you deal with people with psychological disorders, you are not dealing, I don't believe, with a spiritual entity. That is, most of the time, when you deal with somebody who is dealing with anxiety or depression or schizophrenia, it is a fairly common psychological, physical, neurological issue. There are very few ways in which you will find that this is probably occurring at a spiritual level, and here are the main differences. First of all, when I would work, let's say, at this state hospital, most of the people there were very interested, even though they were, like the person I told you I had lunch, a meal with this weekend. Schizophrenic, saw him, he's a street person, and has these very same symptoms that we just saw in these video clips. But I'm telling you, I said this to him. I said, Douglas, I'm be praying for you. And he goes, thank you, bless you, let God bless you, please pray for me. And then he would launch on to something. But there was a very strong reaction when I'd say, I'll be thinking about him and praying for him and help. He was very positive to that. That's a unique quality. I think if you look at the biblical record, what was the reaction that many spiritual entities or demons had to the name of Jesus? It wasn't positive, was it? It was almost a complete opposite, and this is not usually what you find. Another thing that separates out many of what we just saw was in the schizophrenics, very kind of strange or disturbed thinking, illogical or confused thoughts or speech. I have no experience with this whatsoever, other than the fact that some people that have reported that they were clearly in the presence of someone who was demon-possessed said that their thinking of that demon wasn't at all confused. It's very logical. The only experience that I had is secondhand. A friend of mine, I don't know if any of you all had this, but or know of people that have had this experience, but did I tell you about my pastor friend who came out here and was working with somebody out in this area, and a friend of his called and said, hey, could you come? We have somebody here that is showing very clear signs of what we think is like a demon possession. We just want to pray for this person. And my pastor friend went out there. His name is Dan, and he sat there and it was praying with these people. He didn't really know them, but this person that they were praying for, he was convinced at the end was showing signs of demon possession. And he says it was clear it wasn't a psychological thing, even though he's not trained in that area. He said, but what convinced him was just this scary moment as he's praying over this. They're praying that this person would get better and find healing. That person reached up kind of with their hand and pointed at somebody and said to them, who are you to be praying here with these people? Why don't you tell them what you have underneath your bed? And the person, they all looked at him, what's underneath your bed? And it turns out that this guy later on said, yeah, he had been struggling with pornography and some other addictions, and but no one ever knew that. That person knew that. Where did that person know that? How did they know that? Well, most of the time, when you deal with somebody who has confused thoughts and schizophrenic thoughts, they are not thinking this way. There's no access to supernatural information. There's no access to things above and beyond. And in some of the small few cases that we have in which there might be, let's say, a spiritual influence, there could be access to things that no one else has. Finally, just so you know, most of the time when you work with patients and people who are suffering from these things, a lot of them do get better by therapy and also with medication. And my guess is if you took somebody that was suffering from a demon possession, that antipsychotic medication wouldn't make them better. The demon wouldn't respond and become different. And so that's one way that you can also tell that they're probably dealing with separate categories here.
Can somebody be demon possessed and yet look completely normal?
And the answer is you can also tell that absolutely normal behavior could be behavior that has spiritual influences on it. Of course, yeah. Which is probably a more thing to think about more frequently than someone who is dealing with a psychological disorder showing that. Yeah, go ahead.
What about a person possessed on a schizophrenia that describes the people in their heads as demons?
Yeah.
He would point to a spot in the kitchen and say, this is where the demons come.
Yeah, there are indeed those that are suffering from some of these. She mentioned one. That the person will say, the schizophrenic will say, I'm seeing things, and they'll point, that's where the demon stays or comes around, and so they use that terminology. In that case, you would wonder what exactly, and how they're describing it and what their experience is, and is it just a way of dealing with these hallucinations that are coming in that are up here, or are they true external things? And that's when it's hard to know. Yeah, it's a great example of ways in which they might use that language, and it's hard to know, right? By the way, that's schizophrenia in general from lots of different perspectives throughout time that we've looked at. But yeah, go ahead. Do you have a question?
Yeah. So 1/3 you said get better.
Yeah, the law of thirds. A third schizophrenics get better, a third kind of in and out of the hospital or treatment, and then a third that keep it and don't tend to get better.
Okay, so do they remember when they've gotten well, do they remember?
Yes. No, it's a good question. And she said, are there some schizophrenics that as they do get better, they can discuss or talk about what it was like? And the answer is indeed. There are some who have gotten to a point where they can describe, they knew they were falling into this inability to control some of their thoughts or thinking, and they knew they were falling into this, but they didn't know how to stop it. But they can describe it fairly lucidly, what was going on. So that is the case that they can, yeah.
Are there ways that they know of that you can prevent this schizophrenia?
Yeah, schizophrenia, early treatment, usually early medication and early intervention is helpful, but as far as preventing, nothing yet today. Nothing is able to allow us to not only predict who might develop, schizophrenia, but even to be able to prevent it with anything at this point. And by the way, just if I haven't said it, it does strike males and females equally. Mood disorders, we have another element to them that is slightly different in that they have a number of people that throughout in the course of a lifetime that will suffer from this. Some estimates as high as 1 out of every 4 people or 1 out of every 5 will be diagnosed with depression at some point, or at least suffer from depression, so much so that they call it the common cold of psychological disorders. Around 15 million U.S. adults annually will be diagnosed with depressive or a mood disorder. It also is one of those that is probably equal, men and women, as far as sufferers, but it's very much tilted towards women being diagnosed with mood disorders rather than men. And the difference would be that the majority of women being diagnosed or having this may be due to the fact that they tend to show up in a doctor's office seeking help and treatment. Men tend not to show up with this type of disorder. And so there's a larger percentage of women that are diagnosed with this, even though there's belief that probably is striking men and women evenly or equally. Dystemic disorders we'll talk a little bit about, but there is also a distinction, between bipolar and unipolar. How many have heard of bipolar disorders? All right. The idea of manic depression, and that is what we consider this idea of bipolar. Think of polars as the poles that you would find, let's say even the North Pole and the South Pole. And someone with bipolar, of course, would be going back and forth between these highs of manic states all the way down to the depths, let's say, of depression. Now, if it's just simply a mood disorder called unipolar, it would be just, they would suffer from depression, and it would go like this. A person with bipolar 1 disorder, this would be, let's say, the course of a year here on the center screen, and you could see them just simply go up and peak in a manic phase. Then, a couple of weeks later, they might be down in a depressed stage, and then exist sometime in what's called a normal range of emotions and moods, and then spend more time down here, and then cycle back up to manic. So this, for most individuals like us, it would go kind of like this. We would go up and down like this, most of us within the blue bar here. Every once in a while, something might happen that might push us down here or slightly up here. But for the most part, our cycles would not be like this, okay? And this is what you'll find for those that suffer from a unipolar or just simply a mood disorder that would normally be called depression. You would find they'll spend time here in the normal category and then down into a depressed category, and they'll cycle through that, okay? What it looks like now is very, you understand most of these. Let me just show you somebody in the manic phase and what their experience is like. Yeah, in the manic phase. Let's see if it shows up.
At the opposite end of the spectrum from being depressed. They are unusually cheerful, unusually optimistic. They can become euphoric. They can become so excited about the possibilities in themselves, in their world, that nothing seems impossible. And so they will be extremely talkative, physically active. It's sometimes impossible to interrupt a manic and talk. They have what we will call a push of speech, meaning that they talk so rapidly that it is almost impossible, and sometimes impossible to interrupt. You may have to sort of really tap the patient several times, say, please stop for a minute, let me try to ask you something else, and they may not be able to stop. What are your ambitions in life?
You mean my goals?
Yeah.
I call them goals, you call them ambitions. See, we get two different people. I know what you think. I gotta reach a man. I can reach a man right now. Want to reach a man?
Go ahead.
Y'all probably saying, oh, she's anxious to be on TV. We say, yeah. I'm happy because I'm on TV. I always wanted to be on TV on Channel 9. No, Channel 11 because I wake up in the morning, I take my Lord's Prayer, I had this program, Speak Up America. And I say, oh man, I'm a right there, I can do that.
What are your goals in life?
I want to be a surgeon, I want to be a doctor, I want to be a registered nurse, I want to be a psychiatrist. But my main goal, I want to be a psychiatrist. I can read minds really good.
At first look, you might think this patient was on speed or amphetamines because she seems so high and so hyper, but in fact, we know that she's not on drugs and did a drug screen. Her family also was concerned. They thought she might be taking some kind of drug, but she's really high on manic depressive illness, on the manic phase, almost as though there's a little tiny syringe of amphetamine that's going off in her brain all the time, putting her up, giving her this elevated mood. You feel like you have a lot of money in the bank.
I do. I just told you I got in there. $10,000.
Yeah.
I put it in there every month. I'm on welfare. But see, some people that get their welfare, they might go spend. I don't do that. I cash my check, I get $226 now every month. I live off $26 a month. I put her $100 there, boom, put my $100 here, boom, and I add it together to $20,000. I don't want to do myself no more. That's why I can't hurt. It's boring.
She thinks she has lots of money. She thinks she has $10,000 in the bank and so forth, but in fact her family's confirmed for us that she does not have that much money, that she's in fact rather poor. She believes she's going to go out and buy a beautiful white Buick Riviera with gold trim and a sunroof, but in fact she could never really afford such a thing. And these are things she really believes, and that's what we mean by grandiose delusions, because she couldn't be talked out of these ideas. How do you like the medications you're taking now?
I don't feel it.
That seems to affect you.
At night, it just makes me sleepy, makes me drowsy. But in the daytime, I got so much energy, I don't feel it. But what it does is this: it gradually slows while moving around down. It gradually slows my whole body down, so I can go to sleep and I sleep just like that.
You feel like you.
Medication is beginning to mute this patient's third episode of mania.
Okay, slight kind of way in which you can see these characteristics, kind of a push of speech. There's also a phase here that you could see Robert Schumann, the great composer, was able to compose during a manic phases all kinds of works during a manic phase, simply because of the amount of energy. But the problem comes into play when these become, they are no longer containable, or they begin to start having views and behaviors that are way outside of normal, and it begins to turn into almost a psychotic stage where they can't be convinced of things, or they'll do strange things. But
I've always been told that manic is more like violent and hyper and restless rather than like happy. Is there that side of it?
there is. There's both sides. The side that comes in for, especially in the manic phase, isn't always just a pleasant feeling that makes it happy. There's also a strong aggressive side to it oftentimes. It just depends, and it can be fairly violent at times. So, yeah. Yeah, no, it's good. In major depressive disorders, there's things like overwhelming sadness. I'll let you see the textbook for other symptoms that you would see: worthlessness, guilt, suicidal thoughts. All of them characteristic of this particular kind of mood disorder that is known as major depressive disorder. And I'm going to show you real quick a video clip of somebody that's suffering from this so that you can see a key difference. But go ahead.
Would mania stack with speed? They were compared there. What happens if a manic person takes this? Do we know? Yeah, no, there are people who are that have certain disorders that oftentimes will self-medicate, and it just creates even more problems and issues. And so what happens is you have people that probably are self-medicating in many ways that are numbing things. Let me show you this person real fast and just show you. This is a person who's dealing with a major depressive disorder, and you can start to see how this separates out from, let's say, normal sadness that we might experience. This is this is Mary.
I understand something unusual happened on Thanksgiving. You went home for Thanksgiving. What happened?
I couldn't feel anything.
And?
And my son and I were in my bedroom, in my son's bedroom, I realized that I was the devil.
You did what?
I realized I was the devil.
Can you tell me about that? When you say you were the devil, did you feel something unusual?
Like I couldn't get back.
Couldn't get back to where? Back from where?
From everything I thought I had loved. When I realized I probably didn't love anything ever.
One of the unfortunate features of the word depression is it refers both to a normal experience in everyday life and to a disease. And the differences are several. First, the disease occurs as a syndrome. That means that there are a lot of other symptoms that go along with it. In addition, the sadness, the blueness, the melancholy of depression has an interesting specific quality. People who are having depressive illness will not experience pleasure. They will lose interest in things. Life is gray and boring and dull and weary, which is very different from the pangs of grief. In addition, people have other psychological symptoms and physiological ones as well.
Do you feel sad or unhappy?
Feel nothing.
Do you feel happy? The doctors think that you want to die. Is that true?
I want to die.
Is that true?
Mm-hmm.
Have you told this to your husband?
Yeah.
What does he think about it?
Thinks I'm kidding.
Why do you want to die?
Because I'm the devil.
What does it mean to be the devil?
It just means being really evil.
Have you done something wrong?
I never laughed, I never loved, I never forgave.
In your whole life, you never laughed or
Yeah,
loved?
I did laugh. I thought I loved.
But you don't feel that right now.
There's one way of treating this. Let me show you, which is a
Just look at me.
kind of something that's finding a resurgence.
Everything I smell.
You have a body odor?
Mm-hmm. My hair's falling out. I'm disgusting. I'm evil.
In fact, you think that you should be dead. Did you try to kill yourself? Did you really?
Yeah.
Tell me about it.
Took a bunch of pills, aspirin,
When was this?
on Thanksgiving.
So what's happening here is you can see the overwhelmingness of it. One treatment for her, I'll illustrate it right now with this rest of this clip, that has in major depressive disorders in which medication doesn't help, there is another way of dealing with this, and they'll show it here. It's called electroconvulsive therapy,
All her feelings.
shock therapy.
They now were expressed in all their intensity. She was worthless, hopeless, life was not worth living. She felt she was the devil, and she had the idea that the only way to end this terrible pain was suicide. She tried at home. Her husband brought her right to the hospital, and from that moment on, she had to be monitored. We had to have an individual sit with her 24 hours a day, because all she could think of was trying to kill herself. There were hours in the next few days that we had to put Mary into restraint. The alternative was that she would scream and try to kill herself by any device possible. It became necessary to treat her as rapidly and as effectively as we knew how for the drive to suicide and this very severe feeling of unhappiness.
I'm going to clean your head off if you want.
Electroconvulsive therapy is a very powerful way to change the mood of individuals who are very severely mood altered. In this treatment, patients put to sleep, and 30 seconds later is given a dose of a muscle relaxant. Cup is up.
Right button in. The impedance is low. Okay.
At that point, electric current is passed between the electrodes in the head. And that takes anywhere from a half a second to 4 seconds.
Treat.
seconds in order to be a good or effective treatment.
Mary, open your eyes. Treatment's all over.
With a severe form of major depression with psychosis that Mary has.
Mary, open your eyes.
In that illness, medication is usually not very helpful. And so the best alternative is electroconvulsive therapy. What do you remember about the depression?
The depression that I came here with, I don't really remember much about.
Remember nothing about it?
I do remember going home on, being in the hospital here, going home on Thanksgiving, and taking a lot of aspirin. I remember that.
What happened? Thanksgiving.
I remember thinking I was the devil. And taking aspirin, and then my son coming from my neighbor's house and coming into the bedroom, and then I remember feeling bad that I had done that.
You could see just an amazing change. There's like an animation to her, a life to her. We'll talk about electroconvulsive therapy starting on Monday after break, when I'll talk about other therapies, including this one, in treating this disorder. So read that section, and we'll see you then.
Biola University offers a variety of biblically centered degree programs, ranging from business to ministry to the arts and sciences. Visit biola.edu to find out how Biola could make a difference in your life.